Welcome to this Step 3 review on the emergency department approach. This video is brought to you by Roadmap to Residency. The emergency department questions on this exam reward a very specific way of thinking. They want the doctor who can sort the sick from the not sick, who stabilizes before chasing a diagnosis, and who makes the right call on whether a patient goes home or stays in the hospital. Our goal today is not to reteach emergency medicine. It is to show you how these question stems are built and how to attack them under time pressure. Make sure you are also working through your question bank and a trusted review resource alongside this video, because the patterns we cover here are best learned by doing many practice questions and reading every explanation. Let us get started. Here is what we are going to cover today. First, we will learn how to triage the vignette, deciding how sick the patient really is before we do anything else, because that single judgment drives the whole question. Second, we will work through stabilization, the airway, breathing, and circulation sequence that the exam expects you to handle before you ever order a confirmatory test. Third, we will tackle disposition, the decision about who must be admitted and who can safely go home. Along the way, we will walk through several practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your review resources. We are here to sharpen how you take the test. Our first strategy is triage, and it begins before you form any differential. When you open an emergency department vignette, go straight to the vital signs. Look for a low blood pressure, a fast heart rate, a low oxygen level, an abnormal temperature, or a fast breathing rate. Those numbers are the single most important triage signal in the whole question. Then ask yourself one simple question. Is this patient sick or not sick? A stable patient with normal vital signs can tolerate a careful workup, so answer choices that pause to gather information are reasonable. An unstable patient needs an intervention immediately, and the right answer will be the one that protects life right now rather than the one that orders a scan or waits for a specialist. Make that sick versus not sick decision first, and most of the distractors will eliminate themselves. You can drill this pattern in the emergency medicine and critical care sections of your question bank. Strategy 2 is stabilization, and it follows a fixed order that the exam expects you to know: cold, airway, then breathing, then circulation. First, treat in order. When the question describes an unstable patient, work down that sequence and choose the action that addresses the most immediate life threat first. If the airway is compromised, securing the airway beats every other option on the screen, even one that sounds more sophisticated. Do not let a fancier choice pull you past a basic life threat that has not been handled yet. Second, stabilize before you diagnose. A very common trap offers a confirmatory test, like an advanced scan, as the next best step in a patient who is crashing. The exam wants you to resuscitate first. Give oxygen, get access, deliver fluids or the immediate treatment, and only then pursue the diagnostic study. When the patient is unstable, the answer that keeps them alive almost always beats the answer that explains why they are sick. You can reinforce this airway, breathing, and circulation sequence in the emergency and critical care portions of your review resource. Strategy 3 is disposition, the decision about whether the patient is admitted or discharged. This is where a huge number of emergency department questions are won or lost. First, admit the unstable and the high-risk patient. If the vital signs are abnormal, if the patient needs a treatment that can only happen in the hospital, or if there is a real chance of deterioration, the answer is admission. Watch for instability hidden in the numbers, because the exam often buries the abnormal vital sign in a long stem. Second, discharge the stable patient, but only with a safe plan. Discharge is correct when the vital signs are normal, the dangerous diagnoses are ruled out, and the patient has reliable follow-up. Notice that a correct discharge answer always pairs going home with clear return precautions and arranged follow-up. Third, beware the premature discharge trap. The test writers love an answer that sends home a patient who still has a red flag, a borderline vital sign, or no way to follow up. It looks efficient, and it is the most dangerous choice on the screen. If anything is unresolved, do not choose discharge. You can practice these admit versus discharge decisions throughout the emergency medicine questions in your bank. Let us work through our first practice question, and this one is built to test triage and stabilization. A 70-year-old man is brought to the emergency department with fever and confusion that started one day ago. His temperature is high, his heart rate is fast, his blood pressure is low at 80/40, and he is breathing rapidly. His skin is warm and flushed, and a urinalysis points to a urinary tract infection as the source. He is sleepy, but responds to voice. The question asks for the most appropriate next step. Before you choose, notice the vital signs. This patient is unstable, with a low blood pressure and signs of poor perfusion. That is your triage signal. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down. First, spot the pattern. The vital signs are the whole story here. A high fever, a fast heart rate, a low blood pressure of 80/40, fast breathing, and confusion, all with a urinary source of infection. That combination is septic shock. The moment you triage those numbers, you know this patient is sick and needs treatment immediately. Next, apply the rule. For an unstable septic patient, you stabilize before you pursue any further diagnosis. The immediate treatment is intravenous fluids to support the blood pressure together with early broad-spectrum antibiotics. That is choice B, and it is the correct answer. Finally, eliminate the wrong answers. The abdominal scan is the classic diagnose before you stabilize trap, and an unstable patient should never be sent to the scanner before resuscitation. Waiting for blood cultures dangerously delays the antibiotics that save lives in sepsis. Discharge home is the premature discharge trap in a patient who is in shock. The correct answer is to give intravenous fluids and start broad antibiotics. You can find many sepsis and shock questions like this in the emergency and critical care sections of your question bank. Here is our second practice question, and this one is all about the disposition decision. A 60-year-old man comes to the emergency department with 3 hours of chest pressure. He has high blood pressure and diabetes. His vital signs are normal, and he is comfortable now. His heart tracing shows no acute changes, but here is the key detail. His first troponin blood test, a marker of heart muscle injury, is elevated. He is pain-free after treatment. The question asks for the most appropriate next step. The trap here is that the patient looks calm and his vital signs are normal, so a discharge answer is tempting. But an elevated troponin is an abnormal, high-risk finding that changes everything. Scan the stem for that hidden red flag, then pick your answer, and we will reason through it on the next slide. Let us work through this answer. First, find the hidden red flag. The stem is built to make this patient look safe to send home. His vital signs are normal, his heart tracing shows no acute changes, and he is now pain-free. But it buries one critical detail. The first troponin blood test is elevated. Troponin is a marker of heart muscle injury, so this is an acute cardiac event, a high-risk diagnosis that can deteriorate suddenly, even when the patient looks comfortable. The calm appearance is the distraction. Now, why does admission win? A high-risk cardiac patient needs monitoring and treatment that only the hospital can provide, so admission to a monitored bed is the correct disposition. That is choice A. Look at the distractors. Choice B and choice C are both premature discharge traps that ignore the abnormal troponin, and choice C is especially dangerous because it sends him home with no follow-up at all. Choice D, physical therapy for chest wall pain, completely misreads the case. The correct answer is to admit to a monitored bed. This is the lesson from our disposition strategy. Always check whether a normal-looking patient is hiding a high-risk result before you ever choose discharge. You can drill chest pain and disposition questions like this in the cardiology and emergency sections of your question bank. Let us talk about emergency department management principles, the rules that decide so many of these questions once you have triaged and stabilized the patient. First, treat first and confirm later. For a true emergency, the exam expects you to give the empiric treatment before you wait on the confirmatory test. Give antibiotics in suspected meningitis before the imaging and the spinal tap. Give epinephrine immediately in anaphylaxis. Reach for the antidote in a classic poisoning. When a delay could cost the patient their life, the correct answer is the treatment that cannot wait, not the test that simply confirms what you already strongly suspect. Second, rule out the worst diagnosis. In the emergency department, the right next step targets the most dangerous condition that fits the picture, not the most common one. When chest pain could be a heart attack, a clot in the lung, or a tear in the aorta, your next step should work to exclude those life threats first. Choose the action that rules out the diagnosis that would kill the patient if you missed it, even when a more benign explanation feels more likely. You can reinforce both of these principles across the emergency medicine questions in your review resource. Here is our third practice question, and it tests the treat first principle. A 25-year-old woman arrives at the emergency department just minutes after eating at a restaurant. She has hives all over her body, swelling of the lips and tongue, wheezing, and difficulty breathing. Her blood pressure is low and her heart rate is fast. She is anxious and can barely speak in full sentences. The question asks for the most appropriate next step. Notice what is happening here. She has involvement of her skin, her breathing, and her circulation all at once, with a clear trigger. This is anaphylaxis, a true life threat. The trap will be any answer that pauses to test, observe, or refer while she is struggling to breathe. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, name the life threat. This patient has skin changes, airway swelling with wheezing, and a low blood pressure, all appearing within minutes of a clear food trigger. That combination across the skin, the breathing, and the circulation is anaphylaxis, and it is an immediate life threat. Our treat first principle applies directly. The correct answer is intramuscular epinephrine, given right away. Epinephrine is the only treatment that reverses both the airway swelling and the dangerous drop in blood pressure, and there is no time to confirm a diagnosis you can already see in front of you. Now, the key distinction between the wrong choices. Ordering a blood test to confirm the allergic reaction wastes time the patient does not have and never changes what you do in the moment. An oral antihistamine is far too weak and far too slow for a true life threat. Referring her to an allergy specialist treats this like a calm outpatient problem when she is struggling to breathe right now. Every wrong answer delays the one treatment that actually works. The correct answer is to give intramuscular epinephrine immediately. This is the treat first principle in its purest form, and you can find anaphylaxis and other cannot wait emergencies throughout the emergency medicine questions in your bank. Here is a critical exam day pearl that ties together everything we have covered for emergency department questions. Read the vital signs before you read the story. When a long vignette opens, your eyes naturally start at the top and wade through paragraphs of history. Train yourself to do the opposite. Jump first to the heart rate, the blood pressure, the breathing rate, the temperature, and the oxygen level, and in one breath decide whether this patient is stable or unstable. That single judgment frames every answer choice and stops a long, distracting narrative from pulling you off course. Then decide the next action with one simple rule. An unstable patient needs an immediate intervention, so favor the answer that protects life right now. A stable patient can tolerate a measured workup, so a careful next step is reasonable. Resist the temptation to talk yourself into a more sophisticated-sounding choice. The answer that is grounded in the vital signs is usually the right one, and you should only change it when the STEM gives you concrete evidence that you misread the patient. Looking at the vital signs first, then choosing the action that matches the patient's stability protects both your time and your score. That wraps up our review of the emergency department approach for Step 3. Remember the core ideas we covered today. First, triage every vignette by reading the vital signs first and deciding whether the patient is sick or not sick. Second, stabilize the unstable patient in order, with airway, then breathing, then circulation, and treat before you confirm. Third, make the disposition call carefully, admitting the unstable and the high-risk patient and discharging the stable patient only with a safe follow-up plan while watching for the premature discharge trap. And remember to rule out the worst diagnosis, not just the most common one. The best way to lock all of this in is to drill emergency medicine questions in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.